have introduced Dr. Stefan. He's a PA, but um, he is. We're going to give him the title of a doctor because he's very intelligent, very smart, and possibly more smarter than those mainstream medicine doctors. Uh, but Chronic Disease Prevention Management Group would like to honor you with a doctorate degree in medicine, and I think you can learn. We're learning from you, and I mean, the iodine concept came from Stefan. As an iodine is essential because they are cofactor of antioxidant enzyme like magnesium. They're not just part of thyroxine, and also they are inhibitor of aromatase. And it's very good when you are taking sex hormone is taking iodine. This idea came from Stefan, so I'd like to congratulate you for adding more to the table and innovations to the chronic disease prevention management.
Thank you very much for the introduction. I'm going to share my screen here. I'm actually going to show you my website because you guys are talking about a membership-based practice, and that's what I'm in. That's what I am. I'm Iron Direct Primary Care, and this is a direct primary care. So if you guys are not familiar with this, you should be very quickly familiar with this. It's a membership-based model. So for us, it's not $1,000 a month. It's very affordable. For one patient, it's $79 a month. For a couple, it's $119. For a whole nuclear family, it's $129 a month. It's very affordable. We've been very successful, so much that I am no longer taking patients. I'm too busy. I brought on a colleague who's now taking patients. This is a very easy model, and I can teach you guys how to do this, where you guys can join Iron DPC and be very successful in this. Because we're successful because of our ingenuity of teams like this, chronic disease prevention and management, where we are on the cutting edge of the research. The things that we talk about here, they're talking about at A4M a year or two later. I was just at A4M this past weekend. They're talking about iodine now. I don't know how they're knowing about this, but they were not talking about it 3 years ago. Now they're talking about every lecture, iodine, iodine, iodine. And we were the first to talk about it here at my lectures. Dr. Halasa, as you correctly pointed out, methylene blue, that was first talked about here. All this stuff, we talk about it here first, and then the others, they catch on eventually. So yeah, what we're doing here, very important. But today we're going to be talking about the male hormone optimization. Now this lecture, we're going to talk about, some of the research, the studies out there, but we're also going to be putting in some real case examples, because at the conference this past weekend, it was good. They talked about all this research, but it lacked the real world examples of actually looking at these labs and making sense of these things and putting it into clinical practice, as we do every day at Iron DPC. So we're going to spice it up with a lot of clinical case studies here. So we all know that the testosterone is declining across the age spectrum, but shockingly in younger age groups. 20-year-olds, 30-year-olds have low testosterone. Older populations too, but as we'll see in practice, if you run these labs, sometimes older generation males will have higher testosterone than current Gen Z and millennial populations, age 30s, right? So, a 70-year-old can have a much higher testosterone than a current 30-year-old. And this is quite concerning. There are not very good guidelines or hard set points of what is a low testosterone syndrome. We have to look at the clinical symptoms. We can use the labs, but as we'll learn in this lecture, the labs are a little bit challenging to interpret. There's a couple societies, but generally they say, under 300 is a low testosterone. But as we found in practice, and Dr. Clearfield knows, you can have low testosterone symptoms at 400, 500, and so forth. But here's a couple of guidelines there. Some low testosterone symptoms, as we all know: lack of physical performance, lethargy, low energy, low libido, low muscle mass. This is what they're looking for in your documentation if you're going to be prescribing testosterone therapy to someone. But the lesser known ones that the general population doesn't know, that our colleagues don't know about, is that low testosterone is associated with the metabolic syndrome, cardiac disease, increased risk of heart disease, heart failure, increased mortality overall. You die more of COVID. We learned that in the pandemic if you had the low testosterone. And then actually, contrary to popular belief among our colleagues in Western medicine, low testosterone is associated with increased prostate cancer, not high testosterone, as has been thought for a long time. And Dr. Abraham Morgenthaler has been publishing a lot of this, so we have him to thank for that. So this is what we can expect in an average 30 to 40-year-old male nowadays. If we run these labs, we use LabCorp primarily, so that's what we're going to talk about, these reference ranges with LabCorp. Total testosterone, 500 would be, pretty good. A free of 14 would be actually very good, but typically we see it sub 10s in free testosterone and sub 400s in total testosterone in young men, 30s, 40s. We also see low vitamin D, and that's going to be a really common theme here, is how critical vitamin D is for testosterone here. So pay attention to that. Here are a couple cases we're going to see of what a high testosterone looks like, and they're extremely rare. We have probably about 5 or 7 cases total at the practice where we have natural free and total testosterone that are very high. And 3 of these cases, oddly enough, are in my family. So my brother and I, we have had naturally super high testosterone levels outside the reference range. LabCorp will flag us abnormally high, upwards of 800, 900 total, freeze between 16 and 20, or freeze of 18. Vitamin D levels, this was back when we weren't supplementing, when we tested ourselves years ago. We weren't even taking vitamin Ds, but we got a lot of sunlight exposure, upwards of 67 vitamin D, 25 hydroxy levels. So that was good. Now, my brother's estrogen was a little bit high here. Again, this is not necessarily estrogen too high. As we learn correctly at A4M, we shouldn't necessarily be crushing estrogen. We shouldn't be putting guys on anastrozole. We shouldn't necessarily be trying to lower estrogen. Estrogen is a natural protective mechanism. If you have a higher testosterone, some of that will get converted to estrogen. And estrogen, as we know, is cardioprotective. It improves the pliability of the arteries. So I think it's an innate, intelligent design of the human body to protect itself by aromatizing testosterone to estrogen, to protect against cardiac disease, arterial wall hardening. So something to bear in mind. Don't just senselessly use aromatase inhibitors and try to lower estrogen. This is another interesting case. A couple of other guys that had higher testosterone. This is another brother, a total of 1,000, free testosterone 17. All these cases in common, these individuals, including myself and brother, super healthy, training every day, eating super healthy diet, getting sunlight. So all these guys have this in common. This individual actually owned a supplement store as well, training very hard, high vitamin D, 78. This is another individual. So he was a manual laborer. He didn't really train. He just lifted heavy stuff at work. He ate fairly healthy for the most part, a lot of deer meat. Like, this guy ate ancestral diet, like a lot of deer meat. He hunted deer as a man of the earth. But he fell off the wagon for a time, didn't take care of himself, didn't get vitamin D, was chewing tobacco, and didn't train. And you could see over the course of 1 year, he went from a total of 600 free of 19, and he dropped to about a 560 total and a free of 12. So definitely, a bad diet and chewing tobacco and not exercising, that can totally influence a lower testosterone. And it goes very quickly. But the good thing is we'll see is that you can change it very quickly as well. Now we're going to look at some older individuals here. Here is my dad's levels. He is also a superbly healthy individual who trains hard. He never goes out to eat. He eats super clean. Again, ancestral diet, animal-based. Vitamin D is super high. Vitamin D, 25 hydroxy of 140. And I made a point of adding his calcium here because I know a lot of you guys are worried about high calcium with vitamin D. I've never seen an arrhythmia, a problem with calcium in the blood work, anything with high vitamin Ds. And I've had a couple of patients with vitamin Ds upwards of 130, 140. The only problem it gives them is too high a testosterone or a good level of testosterone. So his total testosterone, 685 total and a free of 17. Estradiol, again, of 34. That's fairly appropriate for how high his testosterone is. He had very good cardiovascular risk markers, in my opinion, right? LDLP is a little bit high, 1400 according to LabCorp, but I'm not worried about his LPA2 was low, homocysteine was low, his lipoprotein A was low, his insulin sensitivity is very good, A1C of 5.4. So overall, very good, very healthy. Here's another older gentleman, 64, natural. He actually had some bad liver enzymes, AST 52, ALT 66, total almost 1,944, however, free of 10. Again, when you see that low free testosterone, that's oftentimes a sign of bad liver. They're probably going to have high sex hormone binding globulin. I don't know if it's here or not, but needless to say, he'd probably have a high SHGB. He's going to have a lower free testosterone because his liver isn't so good. So if you can clean up his liver, this amazingly high vitamin D level is going to be very helpful towards maintaining a super good testosterone throughout his life. Again, a lot of people pretty healthy. They don't take medicines, right? They don't get vaccines. They probably do some level of physical training and manual labor. That keeps them relatively high testosterone level. Then we're going to talk about some of the literature here associated with total testosterone status with bone mineral density in adults. We all know in women, very important, estrogen for bone density, but also testosterone, not only for women, but for men as well. People with osteoporosis are more likely to have a total lack of testosterone. Men who are completely deficient in testosterone are more likely to lose bone rapidly. So something to pay attention to in our older generation is making sure they maintain testosterone levels so that they don't get a fracture as they old, because free testosterone predicts prevalent fractures independent of bone mineral density. Pretty cool. So instead of ordering DEXA scans, order testosterone levels in your male population. This can predict who may be getting fractures in their life. We'll look at another cool case study here. Raw milk fast obliterates LDL and testosterone. So this is pretty cool. Someone went ahead. I didn't tell them to do this. They did a 21-day raw milk fast to see what would happen with his LDL and his testosterone. Now, cardiologists may look at this and be kind of happy with the results. The triglycerides didn't change too much, but cholesterol, which cardiologists like to look at, went from 259 to 193. So, wow, very happy. Lower cholesterol. LDL particle count also dropped from 1,800 to 1,200. LDL-C went from 182 to 129. So kind of cool. But his insulin resistance score got a little bit worse, went from less than 25 to 42. He got a bit more insulin resistant, obviously drinking a lot of sugar. That's what raw milk is. Unfortunately, he didn't like these numbers at all. His testosterone didn't get better. It got worse. It went from 626 to 424. His free went from 8 to 6. Not happy, but cardiologists would be happy. His ApoB went from 123 to 94. So the patient was not happy about these numbers, but a cardiologist very happy. Let's see. We went over this. Let's talk about something else. Overtraining. So I deal with athletes, and some of these athletes, including bodybuilders, they do overtrain. So I'd say most general population, is not training enough to crush their testosterone. The training that they do could increase their testosterone, help their testosterone out, right? But there is a population that I work with that overtrains, and it will lower their testosterone levels. So let's take a look at the bodybuilder. This is a bodybuilder running 750 milligrams of underground testosterone and 6 units of HGH per week. So you can see some really interesting things happen here. One, his total testosterone level is 2,000, right? That's what you'll see. It's so high, LabCorp can't even measure a free testosterone. I think we caught one, his free testosterone measured greater than 50. Now, you couldn't read any bigger than that. His total was 2,800. Obviously, your LH and FSH will be completely obliterated here. The only reason his estradiol is 24 is because he's taking raloxifene and anastrozole. This patient was also taking underground growth hormone. Not sure where he was getting it, but it was working. It's 6 units. His IGF-1 shot up to 371. The interesting thing about that, as we'll talk about later, is that it influences the thyroid as well. Note his dihydrotestosterone was very high, 159. Vitamin D also very high because he supplements with vitamin D at 102. Note his free testosterone, his hello, whoever's that, can they mute themselves? Thank you. Anyway, someone mute whoever that is. Dr. Halasa, can you mute that person? Thank you. Okay, so note his free T3 was 4.3. You never see this in adult patients. The only time you would see this, it would be in children. So if you measure teenagers and 8-year-olds, they'll have a free T3 upwards of 7 sometimes, as high as 10. Now, this bodybuilder was injecting growth hormone. And we're going to look at a couple slides that will show studies that show it does suppress reverse T3, this growth hormone, and thus it will increase the conversion of T4 to T3. Let's see. Okay. So thyroid hormone changes related to growth hormone therapy in growth hormone deficient patients. So the most frequent alteration of thyroid hormone balance in patients under HGH treatment is decreased free T4 and reverse T3 with increased free T3. This may be why children also have super high levels of free testosterone, free T3, is because they also will have super high IGF-1 because they're growing, obviously. So let's see here. So this was a patient. Let's see, this good. What is this? Well, growth hormone has measured stimulates energy expenditure and extrathyroid conversion, thyroid reduction to thyroid. Yes, we know that. Okay, so this is a patient. He came to me. He had a low testosterone. He also may have been suffering with COVID at the time, so we had a quite low testosterone of 147 and free of 2.6. He had a bit of abdominal fat, brain fog, fatigue. He said his diet was good, but upon further inquiry, he was drinking, 6 cartons of coconut water daily. He drinks a glass or 2 of orange juice. He consumes a large amount of fruit and also raw dairy. So he tells you it's healthy, but if you really calculate how much sugar, this person was consuming a lot of sugar, upwards of 180 grams of sugar per day. So consuming this super high sugar diet is not very good. This induces the metabolic syndrome. This will cause a low testosterone, high blood sugars, the insulin resistance. And this is actually not too uncommon in the general population, but even my population who's trying to do healthier and eating healthier things, you can totally overdo it on quote unquote healthy things. So this patient, we were able to reverse this quite readily and quickly. We put him on a bit of DHEA. We overhauled the diet. We actually gave him a bit of IGF-1 because his IGF-1 was quite low. We gave him CJC ipamorelin, brought it up to 141. He felt very good. We also treated him for viral illness because his, where was it? His D-dimer, I think, was quite high, if I can find it. Oh, yeah, there it is. D-dimer was 1.35. He was suffering with COVID at the time, so we treated him with ivermectin and so forth and fixed his diet. His insulin went from 18.2 to 3.6 over the course of this protocol, a couple months of changing diet and doing these nutrients, exercising more. So we were able to make a complete overhaul from what could have been, this could have been a victim of, the pandemic, D-dimers is risk for clotting, high CRP, bad lipid panel, and then low testosterone levels. But we were able to make some changes just with taking a dietary history, doing a couple simple nutrients, and then also a bit of IGF-1. He noticed a very good body composition change. A guy at the gym noticed that, he's growing muscle suddenly. So he did very good turnaround here. Let's see, India study, and I don't care about that too much. Prevalence of testosterone deficiency among aging men with and without morbidities. So yeah, you will find very closely correlated the metabolic syndrome with a low testosterone. It really just goes hand in hand. If they're old, yeah, they get it harder, but young as well. Again, we have to go over this because we get this all the time. Doesn't testosterone cause heart attacks? So androgens effect on inflammation. Dr. Halasa will be interested to hear about this. The androgens have been shown to decrease concentrations of inflammatory markers, including TNF alpha, right, IL-6, IL-2. Androgens also increase the concentration of anti-inflammatory cytokine IL-10, right? This is why patients with lower testosterone, they suffered more in the pandemic. And I didn't really agree with FLCCC protocols. They did this androgen suppression deal, never got on board with that. You really want to do the opposite for these patients and improve their androgens, not lower them more. Overall, and cardiovascular mortality and testosterone deficiency, low T levels are associated with chronic medical conditions, the metabolic, the diabetes, the dyslipidemia, hypertension, renal failure, frailty, malignancy, and cardiovascular events. Several meta-analyses and systematic reviews have clearly associated testosterone deficiency with increased cardiovascular disease and mortality. Higher T levels were also associated with decreased risk of cardiovascular events in men greater than 70 years, but not in younger men. I mean, that might be, there might be other reasons for that. Testosterone deficiency and CAD, coronary artery disease. You notice that men with lower levels of endogenous testosterone are more likely to develop CAD during their lifetimes. The severity of CAD has also been investigated as a function of serum T concentrations. 4 studies have noted an inverse relationship between serum T levels and CAD severity, with lower levels of serum T associated with more severe CAD. Okay, let's look at some warnings on testosterone. It can't all be just good, right? This is a brother study. We have 2 brothers, one who abused testosterone for performance use in his younger years, and the other who remained natural. You can see the one brother's free testosterone of 5.8, a total of 369, and the brother who didn't use, he remains a total of 1,000 and a free of 17. The brother on the right, he also suffers with the low IGF-1. So he shouldn't have done this, but if he did do it, he should have used PCT, which he did not do, right? Post-cycle therapy, commonly used by bodybuilders, would be HCG and clomiphene to restart the testicular function. Ideally, you want to use testosterone older in life after they have children, because it can be difficult sometimes to restart the testicles. I mean, it's not the end of the world. There is therapy to restart the testicles, but ideally you start it later in life after you've had some children, or at least bank the sperm. Hypogonadal men have more fat and less muscle. The hypogonadism in male study compared 836 hypogonadal men with 1,326 eugonadal men, which means a normal amount of testosterone. The BMI in the hypogonadal men was found to be 31.5 compared to 28.5 in the normal testosterone. The authors also verified that the odds ratio for having a hypogonadism was significantly higher in obese men. Well, this is because there's a vicious cycle between the obesity, right, and the low testosterone. The more fat cells they have, the more estrogen will be produced. The more estrogen produced, the lower testosterone, more obesity, more estrogen. Very vicious cycle. So you do have to kind of help these men. You have to intervene at some point. Either they have to make radical lifestyle changes. Some men are very easily can do this. Some struggle more. Some do need more intervention. But we still get a lot of fake news, fear mongering on the risk of TRT. So you just have to be aware of this. I would refer everyone to, Morgan Taller's research. If, people are worried about this, you still get a lot of, patients will, or colleagues of ours will be like, well, doesn't testosterone cause heart attacks? Well, I would say if you do it right, if you do it at the right doses, if you monitor the labs, there'd be no problem, right? The patients, they should monitor the labs on testosterone therapy. If they get high hemoglobin, yeah, it's going to increase their high blood pressure, increase their cardiovascular disease. We know testosterone will increase their hemoglobin concentrations, makes them produce more EPO. So they can get high hemoglobin. This can increase iron, causes iron deposition on the liver. That's a liver problem. And then more pressure in the arteries, not a good thing. So these guys who have a rapid rise in the hemoglobin, send them for a sleep study. You will often identify a sleep problem, a sleep apnea in these men who jack up their hemoglobin. So do some things definitely to monitor. Now, if you go to A4M, you will hear different experts say, you have to do salivary, you have to do serum. Well, I was like, well, why has no one done a head-to-head comparison of serum and salivary? No one's done this before. I guess I was the first one to figure this out or ask this question, because I hear all these. Dr. Pamela Smith says, you got to do salivary. And this doctor says, you only got to do serum. So what I did is I did both on myself on the same day for you guys as an observation here. I did the salivary with Access Labs. I put saliva into this tube, and I got my blood drawn at LabCorp. So 900 total testosterone, free testosterone of 20 on the day, and that equates to a testosterone saliva of 97. Who knows what to do with that number? I mean, this is Access Lab salivary hormone lab. So this kind of helped me make sense of it. And we're going to look at a couple other case studies and also understand this a little bit better very shortly. Estradiol, all very good. No signs of the metabolic syndrome, right? High testosterone does not mean you have metabolic syndrome. My cortisol also is very low. That's another lecture story. I did some genetic testing on myself. I have a mutation in my COMT. It's known as the warrior gene. The warrior gene makes me just metabolize all my stress hormones very quickly. So I'm someone actually have no stress. I've never experienced anxiety in my life. And it may be just because I metabolize all my stress hormones very quickly out of my body, which may also allow me to have a higher testosterone, because there is an inverse relationship between the testosterone and the cortisol. The higher the cortisol, the more catabolic, the lower the testosterone will be. So in my case, the reason I may have such high testosterone is because I have a low cortisol. I don't know if that's necessarily a good thing to live with such a low cortisol all the time, but I don't have any stress because of that.
Did you measure your estrogens, by the way?
Yeah, did you see that right there? Did you miss that?
Yeah, I missed it. How much it is?
It was negative. According to Access Lab, no real estrone, no
No
estriol.
estrone? And
Yeah.
that explain actually, because if you don't have estrogens, because estrogens drives the steroid synthesis to make cortisone. So if you have low estrogens, you will definitely have low cortisone.
Ah,
You got my point?
yes.
Estrogens stimulate the metabolism or pathway or shift to cortisone instead of sex hormones. They work together, and the cortisone shifts the steroids to make more of estrogens. And so that explains why you have no estrogens. Nothing is pushing your progesterone and your cholesterol to make enough of cortisone.
Interesting.
I do have a quick question.
Yes.
Okay, so low cortisol levels, for some people, they will be fatigued. At least that's my understanding. So I'm curious where you having low cortisol plays a role in fatigue or anything like that. You don't seem like a fatigued person.
No, I don't experience any fatigue. So for me, it's not cortisol that's an issue. My thyroid hormone has always been low, but the only time I get fatigued is when I'm playing professional tennis tournaments and I'm playing for 2 hours against 17-year-olds at the top level. I mean, I get fatigued there. And I've actually been using NP thyroid to help me get through these matches, and it's actually worked.
So maybe your sex hormones being high are providing the energy, the cortisol, then it doesn't, it's a sign that the sex hormones are dominant, like in a good way. Like Dr. Halasa says, there's a shift where the sex hormones decline and then the cortisol levels become dominant, or they, you know what I mean? So, oh, and by the way, I'm doing some major work on myself. So when I get to the place I want to, I'm going to have a picture of myself without a shirt too.
Yeah, you should.
I'm trying to catch up to you.
You're jealous, right? Is that what it is? Okay, let me add something.
I'm inspired. I'm inspired.
Inspired and jealous at the same time.
You can donate your body to science. I'll donate mine to science fiction.
Let me add something here, very important. The reason why you're giving cortisone for people with fatigue, because you need to consider that they may have chronic inflammatory response syndrome. And that's the reason they get fatigued, and that's why you're giving cortisone to decrease the inflammation. So the right answer is not to give really hydrocortisone. I mean, yes, you need to give the hydrocortisone for those cases to get the inflammation down from chronic inflammatory response syndrome. But it's why you're doing that and giving them that kind of euphoria and putting the inflammation, the fire that's coming from the underlying biotoxins, whether it is fungus or spike proteins. You need to start digging into clearing those pathogens and those toxins and detox them. And once you get to that point, I think you will not need to give hydrocortisone anymore. So it's very clear that in addition to all of this, that Stefan does not have any underlying inflammatory diseases that leads to cortisone to be high or to give him hydrocortisone. In your case, if somebody has underlying inflammatory based disease, like have Lyme disease or have psoriasis and all that, they need to have some hydrocortisone to take care of those extra inflammation. Your sex hormone can do the basic, but when it comes into sex inflammations, you need to have an extra hydrocortisone. I think that explains the whole thing. But it seems like Dr. Stefan, he has no chronic inflammatory, no toxins, nothing going on. He's completely healthy. And you see he's healthy because he has no even extra fat tissue. I mean, I don't think you have any subcutaneous fat, right?
Very minimal. I got a DEXA composition score and it was very low. It's gotten even lower since then because I've been training so much recently.
And you had mold toxicity at one point, right?
That's another lecture. That's another. I have a whole lecture I'll give you on that one. But I did develop some inflammatory markers actually after 2022 as the mold started catching up with me. But it didn't really affect my testosterone very much.
But you did something for the mold. But I mean, for another lecture, but you actually addressed it from more ways than just remediating your house, right?
Did a lot.
You did a lot of things. Okay.
We got a whole lecture on that. I'll do that at one time. Let's look at this one. This is a patient, male in his 60s, overweight, rotator cuff tears. If you have a patient with recurrent tears in their joints, their ligaments, their tendons, that's low testosterone. Testosterone improves the strength of their tendons and ligaments. So we did a serum as well as salivary testing taken same day. You can see a bit of low LH, testosterone really low in the serum. This guy also has low testosterone in the saliva. If you remember what mine was about 90, 95. His is half that at 45 on the salivary. Now, I think the salivary is super sensitive at picking up free testosterone because that's what this level is. It's a free value, and they measure it in picograms per mLs, but it's clearly not the same picograms per ml that LabCorp tests. So you have to, if you're going to use a testing methodology, just use one and test it. Don't do one and then check it with a different sort of testing another time. Just use one because you get too confused otherwise because they're same units, but they're getting two way different values here, right? 6.5 free and a free of 45, but same units. So it makes no sense, but just stick with one. He also had low estrone, low estradiol, low estriol. So again, low testosterone, you're typically going to also see low estrogens as well, because the higher testosterone you have, you're going to convert some to estrogen. But if you have low testosterone in the first place, most of the time you're also going to have low estrogen. It's on occasion you'll see it. Maybe the really, really fat ones, their fat cells will produce a lot of estrogen, and then they'll get the low testosterone. But what I found mostly is low testosterone goes with low estrogens. Let's see. Also, he had low cortisol. What else do we have here? To give you a progesterone estrogen ratio in a male, I don't see how useful that is. I mean, this test is super sensitive. It will measure some level of progesterone. If you remember, mine was about 7. This test will also measure progesterone in males 5. Typically, you see very low progesterone as there should be in men. Men don't produce much for progesterone, some, but really not a significant value or one that's worthwhile. And we might find worthwhile methods for treating patients, maybe for different, maybe sleep conditions with progesterone, but in the natural production, there's really not much you will ever find. Let's see. We looked at this. Oh, actually, that was kind of interesting. 3 recent randomized placebo-controlled trials demonstrate that the administration of testosterone improves myocardial ischemia in men with CAD. All 3 were found that in men with CAD, testosterone prolongs time to exercise-induced ST segment depression, as measured on treadmill stress testing. Testosterone has been reported to have direct vasodilatory effects on the coronary arteries in men with CAD. Now, what cardiologist do you know gives men with an MI testosterone? I can't think of one, but this research can be helpful in reassuring us that testosterone doesn't cause CAD, it doesn't cause heart attacks. Uncontrolled hemoglobin, uncontrolled liver dysfunction, yes, will lead to the metabolic syndrome, the CAD, etc. Manage those. There's ways to manage those. We have a whole lecture on how to manage these risk factors. But testosterone itself is protective against CAD. So let's talk about the brain and testosterone. This is a 36-year-old ex-college football. He received multiple TBIs in college and could not go pro, unfortunately. After graduating college, he gained weight over the years. He came across the carnivore diet before coming to me, and he was doing organ meats, and chemicals and seed oils were gone from the diet. This guy was really trying. He was doing weight training at least 3 to 4 times a week, but he was still having trouble gaining muscle and losing fat. He just didn't feel like he once was. We see some of his lab values here. His thyroid, not terrible, really. I mean, T3 could be better, but 3 is fine. B12 is good. Insulin is kind of high. Look at that number, 22 insulin on a fasting test. That's abnormal. That's way too high. You will see that very routinely if you measure insulin levels. And people with a metabolic syndrome, they will have high insulin. His hemoglobin A1C is 6. His testosterone total, 219. His free of 10.7. This guy's just not feeling himself. Vitamin D is also low, 36.5. So he's got to give me permission to share his story because he thought it was so important that people should understand this. He was able to replace a lot of his fat mass with hard muscle, and he feels very strong. It's actually helping stabilize his pain. He suffered some injuries in college football in his back, and the muscle is literally helping hold his spine together. So testosterone is very helpful for pain management in these cases where it strengthens the ligaments, the tendons, the bones. Literally, you got to think of your muscle as basically a structure to support your spinal column. When I worked in spine surgery, because I worked in spine surgery for a spine surgeon for a while, the type of patient that came in for spine surgery, they weren't typically the muscular guy. They were soft. They were literally just crumbling in on themselves. They did not have the support structure to prevent gravity from crushing their spine and causing herniations. So testosterone is a great pain therapy. If you can combine that with resistance training, these people will grow muscle and they're literally going to pull themselves back together again. Let's look at something a little bit interesting. The effect of statin therapy on testosterone levels in subjects consulting for erectile dysfunction. Both total and calculated free testosterone levels were significantly lower in subjects taking statins when compared to the rest of the sample. So the use of statins was also associated with reduced testes volume and higher prevalence of hypogonadism-related symptoms and signs. We have a lot of theories as to why this might be. Statins have a lot of problems associated with them. But one problem that may be is because they do lower cholesterol. And, well, cholesterol is essential for pregnenolone, and pregnenolone is the mother of all hormones. If you don't have cholesterol, you will not have hormones. So crushing cholesterol may also crush testosterone levels. So something to monitor in your patients on statin therapies, right? There's other drugs that crush testosterone, opioids being one of them. Marijuana, I don't think does any good for people's testosterone levels, but statins as well. Endogenous and exogenous testosterone and the risk of prostate cancer and increased prostate-specific antigen PSA and meta-analysis. So this is important for me. As you guys know, I've been involved in the prostate community trial. So we want to make sure we're not causing bad prostate with giving people testosterone. But prostate cancer appears to be unrelated to endogenous testosterone levels. TRT for symptomatic hypogonadism does not appear to increase PSA levels, nor the risk of prostate cancer development. So that's reassuring. You can point to this study again, other ones by Morgenthaler, but this meta-analysis was very reassuring as well. But let's look at some case studies. As I said, I was involved in the prostate community trial. This patient, he's age 60, never got the jab. He's about 200 pounds, 5'9". So that tells you already a little bit about him. He's a bit overweight. He drinks 5 to 7 glasses of wine a week, beer, 4 to 5 bottles a week, 4 to 5 shots, cocktails per week. It's a lot of alcohol going down his body. He's had some prostate issues for a while. He's had MRIs and monitoring. His prostate is pretty big and he's got symptoms of it. Here's his hemoglobin A1C, as you might expect, drinking that many calories. A1C of 6, his PSA is 3. His IGF-1 is 83, not good. His vitamin D is 44, kind of what you can expect. Testosterone of 171, not very good total testosterone. Estradiol is 9.9. That's estrogen not good. Again, estrogen is cardioprotective. It improves the pliability of the arterial wall. One reason why testosterone might be cardioprotective, as we saw in those previous studies, is because higher testosterone increases estrogen, and estrogen is cardioprotective. So it may not be necessarily the testosterone that's cardioprotective. It's estrogen, but you get estrogen as a byproduct of testosterone. His DHT is also super low. Some people may say, high dihydrotestosterone, that's going to make the prostate grow. Well, not in this guy's case either. I mean, he has low androgens, low DHT. Still has prostate symptoms. Here's some other really bad metabolic markers: insulin resistant, 44, small LDLP of 1,000, triglycerides of 225. That's what you'll see in someone who's drinking alcohol, is super high triglycerides. So the moment you see that, first thing you have to ask is, hey, how much are you drinking? This guy was drinking. So we had a long talk with this guy, and we actually put him on the ivermectin protocol, and his symptoms did improve. That's another lecture we did with.
Hey, Stefan,
yeah.
I didn't see, was there estrogen levels by chance?
Yeah, did you see that? Super low, 9.9.
So I'm curious, though, when I think of the prostate gland, and especially hypertrophy, I'm thinking in terms of estrogen dominance now, and then low progesterone at the same time, meaning that the estradiol wouldn't necessarily be high, but relatively there would be a dominance. Any thoughts?
I don't think that's it. I don't think that's it. I mean, from what I see, low testosterone goes hand in hand with low estrogen. Progesterone is neither here nor there in men. If you measure it, it's not detectable for the most part. I mean, it might have some modifiable effect on prostate. That needs to be studied more. I mean, I've seen a couple mice studies on that.
Well, then I think that would be a sign of estrogen dominance. There's more estrogen than progesterone. Like you said, the progesterone's neither here or there. It's essentially absent. Perhaps I don't see a measurement, but
yeah, but the progesterone is not produced really naturally to much degree at all in the male.
Wait a minute, are you sure?
Yeah, I've measured it. Did you see the previous measurements that I had?
But no, as a rule of thumb, though, and that was the whole thing. I'm just throwing this out there just to, to massage these ideas and make sense of it, because we were talking about low progesterone. In fact, evidence that progesterone can help balance out the prostate gland, because if estrogen is sort of over proliferating and it's not in check by progesterone, for which it needs to be, they're opposites. That low progesterone or estrogen dominance would be the primary driver of prostate hypertrophy.
Well, this lab, I don't think they come up with what is the difference between estrogen. They come up with only estrogen, right, as a total, without knowing what is estradiol and what is estrone there, right?
Correct. If you want that, you have to order, I would say, the salivary is the most sensitive.
I think that's better, because right now we don't know if this is estrone dominant or, we're looking, estradiol is good. Of course, you need estradiol because it's good for the cardiovascular. Yes. Estradiol works different from estrones. Estradiol is anti-inflammatory. Yes, it's proliferative, but it increased the high density lipoprotein, and it's not inflammatory like estrogens. Estrogens is inflammatory. So I think that where you need to come up measuring estrone and estradiol and see the ratio. And if case the estradiol is low,
Wait. What
then you
ratio?
give,
Because this ratio that they're calculating here, I think the lab did an error. This is the only calculation I know is for women. We don't have a calculation of estrogen progesterone for men.
and I'm talking about estrone and estradiol.
Ah,
Yeah, so that ratio also needs to be checked, I think, because the problem is not with estradiol as a part of estradiol. Estradiol is a good thing. We need it. And yes, testosterone convert to estradiol. But estrogens, we have a problem with. And that's where I think we need to start measuring it and then come up with that ratio of estrone and estradiol for the men. But for testosterone to estrogen in general as total has to be above 15. Do you agree that? What is the ratio between testosterone and estrogen? Has to be above 15 or 16. What is your ratio?
I don't really have one. I based it off of the symptoms.
Right. But that's what we trying to find out whether it's estrogen dominant or not. In this case, what is the ratio between total testosterone and estrogen? Do you know here?
Well, in this case, is testosterone saliva was 45. All his estrone, estradiol, and estriol were all negative. So he really didn't have much detectable on estrogens.
Okay, so he needs testosterone plus he needs estradiol, this patient, right?
Well, we can assume that when you give him testosterone, he's going to produce
Yes. That's another option. So you just give them testosterone, and if the estradiol is not picking up, then you may need to give them estradiol. But for this case, exactly, just give them testosterone, and don't worry about the estrogen dominancy here because he has zero estrogens. But after 3 months of giving testosterone, it will be good if we measure the estradiol and estrogens and making sure the estradiol is picked up and you don't have too much of estrogens at the end of the day. Otherwise, if there is no estrogens, you don't need to even add progesterone. It's all reasonable. You need to make sure that you do the lab and then you do the treatment based on the data from the lab.
Yeah, it looked like Dr. Clearfield had mentioned that the ratio you were talking about testosterone to E2 is supposed to be greater than 20, I think. It was in the
Yeah, different from one book to another. Some of them above 16, some of them above 20. That's true. It's the range between 15 to 30. So if you go with a red range and you say, hey, let's go with 20, yes. I agree with 20, yes.
All
right.
All right. This is a case patient, another prostate community trial patient. He had the prostate symptoms for many years, going to pee many times a night, 1 to 2 times. So we put him on testosterone, and we did the ivermectin trial. The ivermectin probably reduced his PSA. That's something that we learned in the trial, is that the ivermectin can reduce PSA levels. But note here, I put this guy on testosterone, and his PSA went down, which is something to note here. This is contrary to what many urologists might tell you, is that it will go up, but it went down. And he also had improvement of his nighttime urinations.
Which people is being measured their estrogens, because what we find that when you have prostatic hypertrophy or prostatic cancer, their biopsy is very rich with estrogens receptors. I think it's E2 or E1. But it would be good if those patients is being measured estradiol estrogens. I think we need to make sure that those things are being measured, because it gives us clear understanding of where we are or where we at. Estradiol is a good thing to have it normal in the man, but excess of estrogens is not something we want. And if we, then we have better control of the case, possibly. Yeah, because we have to come up with why there's prostatic hypertrophy. It's not because of testosterone; it's because of the estrogens.
It is. And it's not a lack of ivermectin either. Ivermectin, I've learned it does help control the symptoms, but the moment they stop the ivermectin, the symptoms can come back. It might last some time, maybe they get weeks, maybe they get months, but it always comes back.
Is inflammatory, and it produces interleukin-7. That's the inflammation kind of what they do. And I think ivermectin inhibit the Th17 and interleukin-6, so decrease the inflammation that is driving the swelling of the prostate, and so it's kind of shrinking it by its anti-inflammatory effect. Once you removed it, yeah, but I think the root cause, it's better to increase the testosterone and making sure you don't have an excess of estrogens. In case, if it's the case, you may need to add progesterone there. But for those cases, when you give them testosterone and you measure it after 3 months and testosterone is being normalized, did you measure the estradiol and estrogens?
Yes, I typically do, but not the estrogens. So when you measure the labs, it's very expensive to measure estrone and estriol. I have to do salivary. So unless you know a better way to measure it.
Okay. Yeah, just to out of curiosity, so we can gauge better, and then if they have low estradiol, even according to Dr. William, and they have normal testosterone but low estradiol, then you may need to give them estradiol, because estradiol increases the high density lipoprotein, which helps at cardiovascular protection.
Yeah, I was just going to mention something else too, is that I see that you gave lactoferrin and ivermectin, and with an elevated PSA, I know it's not extreme, but it makes me wonder if there was maybe the beginnings of or underlying prostate cancer at the same time, because we know that there's evidence in the literature that the combination of ivermectin and lactoferrin there's a mechanism that is bringing or making the cancer cells to go down.
Yes. Yes, indeed. It's
So,
quite powerful.
I was just saying, it's like, which one is doing it? It sounds like it's a safe way to feel confident to give TRT with an elevated PSA to sort of cover, like you did with ivermectin and lactoferrin. That, to me, that sounds like a great combination in that context.
Yes.
Have you tried, Stefan, have you tried in prostate cancer patients the same regime?
No, I haven't seen any prostate cancer patients. No, I don't have any. I have large prostates, but no cancers.
Or we don't know. Maybe they haven't had a biopsy. They haven't seen a urologist yet, perhaps.
I've had some with biopsies. I've had some with MRIs. I have not had a patient with cancer.
And they didn't have a free PSA. They just had a total PSA, right?
We do prostate-specific antigen.
Yeah.
Reflex to free. It would reflex if it needed to. You want me to get it freeze as well? And where's the?
That will help you. It is an early indicator to see that whether patient is developing a cancer or it is just the BPH.
Okay. We'll get freeze as well. It'd be more helpful. We talked about cardiovascular. I wanted to mention this one because I was A4M this past weekend, and I was so irritated by every speaker, especially the female speakers, saying vasectomy is my favorite method of birth control. And I was like, well, vasectomy may cause prostate cancer because there's been meta-analysis on this. I wouldn't say it's the best way to prevent children. I mean, there's a risk to every procedure. And we don't know why, but we just know the association. There may be some understanding in Chinese medicine, right? Blocking the qi flow, blocking the energy flow, the seminal vesicle. We know that blockages of qi induces tumors and growths if you have any understanding of Chinese medicine. So I don't agree with vasectomy as perfectly safe or as a good way to prevent children. Don't think it's safe. I think that this needs to be discussed with every patient who is deciding they want to do a vasectomy. They need to read this meta-analysis of 16 million participants that found that vasectomy increases.
You know why?
What's that?
What's the mechanism is causing prostatic cancer?
That's what I said. Modern medicine does not understand the mechanism. I suggested a Chinese medicine mechanism, but we don't know why.
I'm wondering in simple terms, if that kind of an injury, which it is an injury, any procedure, surgery is an injury, is causing an autonomic nervous system imbalance, so that there's more sympathetic, like along the meridians, however you want to see it, that there's that's causing almost like PTSD of that area, and the nerves in that area are probably, or could be, having sort of a sympathetic dominance, which any kind of sympathetic dominance leads to chronic inflammation, and probably leading to Th17 polarization, leading more towards cancer. Just as an idea, as a simple principle to follow, because that's what it seems like acupuncture points and Chinese medicine is really addressing. It seems like it's addressing imbalances in the autonomic nervous system, which reflexively, when put into balance, can affect, the other organs by reducing their inflammation, and getting the immune status of that area back into balance.
I like it.
Just thoughts. And those are just
possible to
thoughts.
me.
One question, how long did you give the ivermectin and lactoferrin to these patients?
If you remembered my lecture, we found that it works very quickly to provide relief of symptoms. And we typically will repeat the PSA in the labs within about 2 to 3 months to see if it's gone down. And we've seen in some patients the PSA will go down. But the symptom relief, you'll see that in about a week of using ivermectin and lactoferrin. So you'll know in a week if it works or not. So that's pretty cool.
Have you seen their PSA goes down to like within the acceptable limits?
That remains yet to be seen. Where I actually stopped using the ivermectin because I found that it's not a long-term solution. And so now I've changed to using high doses of iodine. So I'm going to be seeing if iodine provides a better, more long-term effect. And I may start doing what Dr. Halasa suggests, is progesterone, to see if that has an effect on the prostate as well. But ivermectin will always be in my repertoire because it's so effective at symptom management. But I don't like symptom management. That's what allopathic medicine does. I want to find the root cause. I want to fix this thing.
So what dose of iodine? You said I will start high dose of iodine.
So you can do the urine halide testing, but minimum 12 milligrams, if not to 25, upwards of 50 milligrams if they can tolerate it.
And you said also progesterone. What dose of progesterone would you try?
So I'm trying currently 30 milligrams of progesterone at night. It's particularly in men who can't sleep with prostate symptoms, because it helps with sleep. That and pregnenolone helps with sleep.
But do you think that would also help for prostate if it is enlarged to shrink it?
That is Dr. Halasa's theory, and I will put it into practice to see, and we will observe and see if there's symptom relief or improvement in the PSAs. I think iodine is probably the more potent mechanism. Progesterone may be a complementary mechanism.
Well, and I have seen evidence in the literature that progesterone, is playing a bigger part in this strategy. But from a mechanistic standpoint, I can definitely see how progesterone, we need to, I like the idea. I buy into it. It makes sense to me that we have to always counterbalance everything that we are optimizing. And when it comes to hormones, just doing one, I'm buying into the idea. It makes more sense to me that we have a balanced approach, and that progesterone is a great balancer of testosterone, especially because we know some of it's going to be converted to estrogen. And even then, there's still this, most people are estrogen dominant unless they're as fit as you. I'm starting to see that progesterone needs to be a part of the male hormone approach, but that's just where I'm at right now with it.
There's really
But
no.
in a case where you see the patient has a possibility of a prostate cancer, would you apply the same strategy?
I would do iodine, ivermectin, lactoferrin, progesterone. Yes, I would add that as well. And I would probably do if they had very low testosterone, I would probably replace testosterone as well, because we found that the low testosterone increases the prostate cancer. Now let's see. Strict keto crushes testosterone. This is for my my strict keto people out there. So this patient, he came to me sad, standard American diet, seed oils, carbs, no resistance training. Kind of a typical pattern you might see on the lipids, insulin resistance score of 81, not good. We did the salivary hormone panel on the SAD diet. His testosterone actually wasn't that bad, 77, estradiol 1.2. Where's the estrones? For some reason, maybe Access Labs back then didn't measure estriol and estrone, because now they do. His DHT was normal, progesterone 5. That's kind of what you'll see in a male, 5 of progesterone, salivary. So remember this testosterone level of 77. Remember this, because he goes keto now. He's done strict keto diet. He feels great. He's training on the X3 resistance system, and his testosterone saliva, it drops to less than 5. We also measure estriol of 11.9, a little bit high. Estrone of 4.2, a little bit high. So this was so wacky, I didn't believe it at all. And I called the lab and I say, what the heck is this? We need to retest this. And so that's exactly what we did. We retested it, and it confirmed low testosterone, like of 7, like what you see on like a super low, like maybe a female level. I'm like, what's going on here? So, but he felt great. It didn't match his clinical symptoms. I was like, well, he didn't want to, treat it at all. I was like, well, you want to stay keto? You want to add a little bit more carbs? So he added a little bit more carbs, and his insulin resistance improved. Still, you remember his insulin score was like 81, but now it's less than 25. He's improved. He's adding some carbs back, and his testosterone, mind you, we're looking at LabCorp values, still a low free testosterone at 9.7, a total of 655, 652. So better, but this is something I found recurrently, and those in the keto carnivore community, when they do keto carnivore, measure their hormones. I find this again and again. They will lower their testosterone. They will lower their thyroid function when they do not eat carbohydrate. So it's good for managing the metabolic disease, the keto and the carnivore. It's bad for the hormones. So they have to do probably hormone replacement or add on a little bit of carbs. But if you're doing therapeutic keto to manage some disease, you're probably going to have to do hormone replacement as well. Let's see. Testosterone deficiency is one of the major endocrine disorders in chronic kidney disease. Well, yes, we know that. Androgens and diabetes in men results from the 3rd National Health and Nutritional Examination Survey. What do they find? Let's see. While the directionality of the association between low androgen levels and adiposity remain unclear, our data are consistent with the hypothesis that androgens may directly influence glucose metabolism and the development of insulin resistance independently of the effects on adiposity. So, yes, that's true. We talked about the kidney disease one. Oh, this is repeating. What is this? So let's look at, here's some more.
Before you move, can you expand on that a little bit? Because
the kidney, yes. So
now with the androgens, you say that androgens and its effect on the
may directly influence the glucose metabolism. I think there's a couple reasons for this. One, if you think of it from the muscle-centric medicine approach, as I've discussed here before, is that when you have a higher muscle mass, you will be able to tolerate carbohydrates and store glucose correctly in the form of glycogen in the muscle. This is probably best with exercise, physical training. So if you combine physical training and you have higher androgens, or you give testosterone replacement, you will make the patient more carbohydrate tolerant and thus improve their glucose metabolism. So it's not enough, I think, just to give them testosterone. They actually have to do resistance training too. But I think there's some studies to suggest that just giving testosterone independent of exercise can improve their metabolic syndrome. So
As long they don't produce too much of estrogens, you're good. But once you're moving it and you have too much of estrogens, then that's a problem. But I think that the saliva test is necessary if it's the only way to measure the estrogens and estradiol, because you need to keep the estradiol normal for the cardiovascular, and you need to lower the estrogens and preventing any extra conversion of testosterone to estrogens. And if it's not being done by the blood, then maybe the saliva will give us more better data.
yes,
I think that's what it. But you're giving iodine. Iodine itself is aromatase inhibitor.
yes.
If you give iodine, possibly you don't need progesterone. So it's all about what you're doing to the patients, which definitely come up the reason why you don't have estrogens, because you're taking iodine in
Well,
yourself.
iodine actually increases progesterone. It synthesizes progesterone.
What, iodine?
Yes.
Yes, and plus it inhibits the aromatase. It's a
Yeah.
very powerful aromatase inhibitor, iodine. That's the reason, those cases with cystis, breast cysts,
Yes.
you iodine, it
Yes.
diminishes, goes away. And I think iodine is a good treatment for all polycystic diseases, regardless of what it is.
Regardless.
Because it antagonizes the proliferative effect of the estrogens. You have to know that excess of estrogen, even according to Harvard Medical School, it's carcinogenic. I'm not talking about estradiol. I'm talking about estrogens. It's carcinogenic, and just recently they are emphasizing on it. But we need to encourage the doctors to measure the estrone and estradiol. Estradiol is not a big deal because it's coming from the pregnant. Estradiol and estrogens are the most important ones.
Yes. Yeah. I gotta get a quote with LabCorp to see if I can start measuring estrone. To see how much that costs. So this is one of my recent supplement protocols. I got my vitamin D up to 138. And again, I had no hypercalcemia. I had no arrhythmias with this. But what it did, and I was taking 3 drops of iodine. And this is what you'll see on serum if you measure iodine. So don't bother measuring serum. You're just going to panic the patient. It's going to be high. If they take iodine, the serum is going to be high. Don't measure that. Okay, this is just for like a proof of concept. But when I took this much vitamin D, I'm pretty certain it was that maybe the growth factor I was taking as well. It increased my free testosterone to 31.8, which is one of the highest values I've seen naturally. Typically, the only way you get this high I've seen is when you're injecting testosterone, which I've never done. And that's the only way to achieve a free testosterone of 31. Typically, injecting about 100 milligrams, you can bring it up that high.
Well, if you're inhibiting the aromatase, then your testosterone will go high.
Yeah.
I think that's one of the reasons why, possibly.
Possibly. Or the high vitamin D or the growth factor. I think maybe a combination of everything, at least to kind of super physiologic levels.
Yeah, let's make sure that people who are taking vitamin D and they're old and their level is high does not mean that the vitamin D is producing its signal. In other words, functionally it's working. I think we need to measure the clotho, because the clotho, if it's low, even if you have normal vitamin D, the signaling and downstream is not necessarily working. So once you give clotho, then the efficacy of vitamin D goes high, and then you get the benefit of the effect of vitamin D. So clotho needs to be introduced. I think Dr. Joseph is the pioneer in this field.
Who is measuring? Which lab do you use for measuring clotho?
Ginfinity, literally. He's
Ginfinity, okay. Okay.
Yeah, he does the NMN, the really good product, and measures, but he's got a anti-aging panel. And clotho was always very difficult to try to measure because there was maybe 1 or 2 labs, maybe overseas. It costs like $800. It's like, yeah, right. So his
How much
panel
does this panel cost?
for him,
Anti-aging panel?
yeah, so I believe the physician cost for the whole thing, it's going to measure intracellular NAD plus and other senescent inflammatory markers. Okay. I'm still sort of acquainting myself with his lab. I did it. I'm waiting for the results, and then I'll actually present on it then.
I did use that lab, and every patient I ordered, everybody's NAD, intracellular NAD plus was low, and
are you talking about? Well, they should be low
definitely.
because they decline with age after the age of 25, I believe. Don't quote me on that, but everybody's intracellular NAD plus levels in general, my understanding, they decline dramatically, like by 50%, by something like 40 or 50. Or are these people that you tested people who were taking some sort of NMN product? We know NAD plus doesn't affect the intracellular, it doesn't get inside the cells. At least there's still no evidence out there suggesting it. It may make people feel good because it might have a neurotransmitter effect. And then there's 5-amino-1-MQ, which can help to optimize the recycling of NAD plus inside of the cells because it's modulating an enzyme that blocks that recycling mechanism, putting together the different components back into NAD plus. But NAD plus is very important for, it's a major regulatory molecule. I mean, obviously it's in the, it's required for complex 1 of the electron transport chain. Number 2, it's activating the sirtuin genes, which would turn on AMPK and trigger mitochondrial, or trigger autophagy and mitochondrial energy generation.
Pop quiz: which food has the best source of the precursors of NAD? Anyone know?
Give us
I'm
a
gonna
multiple
eat.
choice on this one.
I think
Stefan.
let's say red meat.
Red meat, yeah.
I was going to say meat too. So thanks to your article you sent me, several months ago.
I think Clotho will be the good thing to measure the efficacy of all your anti-aging therapies. So before you give 6-hormone, before you give anything, you measure the Clotho, and then you give your 6-hormone, the oxytocin, everything that you think is right. And after 3 months, if the Clotho does not go up or does not go up to the level you want, then it will justify giving Clotho. I don't think that giving Clotho from the beginning of the course of the treatment. I think it's Clotho and exosomes has to be your regenerative part, has to be the last thing you work on, because you may increase the Clotho by just giving oxytocin and 6 hormones and optimizing the health, and you don't need extra Clotho. But if all of this is failing, then the patient needs to be given extra Clotho from outside.
Well, I'd like to, I'm planning a part 3 lecture for Clotho. I mean, literally every disease state is associated with low Clotho levels. I understand your thinking about it, but I'm imagining that Clotho is kind of like the other things that we want to optimize, but it's very, very important. It's a luxury. It's a gift to be able to have Clotho, because that gives us an incredible advantage, especially for people with chronic inflammation who are still struggling to get over the hill, get to the other side of health, as they're fatigued and, their metabolism is all screwed up. But with all the things that are affecting us now, and again, it's kind of like how we said everybody over the age of 40 needs oxytocin. I mean, I have lots of patients doing oxytocin at age 30. I imagine that Clotho will become a much more natural and normal thing. It's just right now it's such a luxury that but I can see how, I mean, look, if Clotho, I mean, there's an association between Clotho and testosterone. That was one of the articles. There's lower testosterone with lower Clotho levels, and that's not even having to do with, it doesn't matter which age. So
yeah, but once you give the testosterone, the Clotho may go up, right? And so you don't start with Clotho in the beginning. I think Clotho will be good if you mix it with exosomes and give it after you optimize. You did everything, okay, and
Well,
still Clotho is low. Let's give Clotho and exosomes, and I think we can mix them together, load them inside exosomes.
well, and I'm coming from a place too. I mean, keep in mind when it comes to, we have to consider age when it comes to testosterone, because if they're under the age of 50, for the most part, we can start them on enclomiphene to help them to produce more testosterone, or to prevent the negative feedback that excess estrogen is having on the hypothalamus pituitary gonadal axis. You know what I mean? And so it seems like we need to consider, before we even give testosterone, the age of the patient, and if most likely they're going to be able to produce their own testosterone, because if we give the testosterone, then their reproductive ability is going to go down.
I agree
That's
with you 100%. No, I'm just saying in general, whether you're giving it directly or indirectly, you need to increase the testosterone. Yes, I agree with you. Before 50, in clomiphene, and actually, even after 50, you may need, if the testosterone itself is not enough, then you may need to give in clomiphene, because you don't want to have that feedback inhibition of the gonads, and they end up with atrophy. So I agree with you 100%.
Yeah, and the Clotho thing again, that's just me, forward thinking and imagining what it's going to be like when it becomes more common. And of course, if we can have access to the probiotic by Dr. Ruggiero, I mean, it's still, the price of it is just not going to be for most people, but to have a microbiome that may be helping to turn on the Clotho gene on more, or it even produces clothopeptide. I mean, I think that would be even better. And then clotho can be, again, more thought of as the regenerative side of things when necessary, because we would be theoretically producing more of our own clotho naturally. But yeah, I'm just throwing around the thoughts, that's all.
When you say that the red meat has a high clotho, so that means that the plant-based diet and vegetarians don't have a clotho. They have a highest longevity.
What are you saying? The plant-based diet doesn't have...
Plant-based diet or the vegetarians, like us, we are lifelong vegetarians. Okay, we don't eat. So, but in vegetarians, the longevity is very, very high. I'm just
No,
wondering.
you don't talk
I
about
mean,
the clotho with meat. Like that was the NMN. What is the highest, right? You got my point. The relationship between, we're talking about the NMN with what is the highest thing, has a high NMN, was the meat, not the clotho. You got my point? Patel, I think you got confused there.
Yeah, the association I think that you're seeing, Dr. Patel, is, and this is based on all the different articles, is it goes both ways. Clotho, a drop in clotho leads to chronic inflammation and degeneration.
No, she's not asking that. She's asking.
No. What I'm saying here is, she said, how come on a lifelong plant-based diet, like you said, you've grown up on, you've been on your whole life, in general, the longevity is higher on average, probably, with people on the plant-based diet. And I'm saying probably because they are healthier, they have less inflammation, and because they have less chronic inflammation, they are producing more clotho. It goes both ways.
Yeah, but I think what she said is that we be talking about.
No, that is true, Dr. Halasa. But Dr. Joseph's explanation is also right.
But your question was with the
yes.
clotho with meat. No, that's not with
No,
meat.
no, it was right.
It was an NMN with meat, not the clotho. You got my
right.
point? So yeah, so that's the NAD and NMN. It's more rich in the meat. Does not mean the beans and all that, they don't have it, right? But that's nothing has to do with clotho here. Clotho, I think clotho it's a peptide signal from the body, and its genetic makeup has to do, and aging slows it, decrease it with age, right? And possibly with interference that we're doing with sex hormones and oxytocin, and preventing the switch to cortisone would definitely keep the Clotho high. But in case the Clotho we did everything and the Clotho is still low, then we start going with regenerative route and start giving exosomes and stem cells loaded inside. By the way, you can load Clotho with exosomes, just the exosomes that from Audrey, by using just the extrusion part. You don't need the sonication, just the
What do you
extrusion.
mean by you can load Clotho with exosomes?
You can take the Clotho and put it in your syringe that you're doing and just pass it through the filter. You don't need the sonication part. And that will help to put through the sharing process, the sharing
Yeah.
it will load the exosomes with Clotho. And I think it helps to protect them from
So
being
where do you get the
degraded.
Clotho?
We're working on it. There's some companies that already have it. I'm working on a big company for that as well. Hopefully they will come and sponsor us for that. Yeah.
I thought
Yeah,
that
but
Dr. Joseph was using Clotho, wasn't it?
Yeah,
Right?
he used a company, two of them, right?
yeah, I just received it. It took forever. I ordered the Clotho from Bucky Labs, and then I'm working on the augmented Clotho from the Neo 7 Biosciences lab.
Right.
But we have to order in like bulk order. I mean, we're just talking like 12, 13,000. But we have several patients that are very serious about getting started. So collectively, if we can get everybody to interested, they know who they are, then and we all go in at the same time, then we can also test out that. But I'll be testing out I'm looking at it, the Bucky Labs Clotho. It's not as potent, but it's more convenient, and this one is one definitely probably we can load into the nanoparticles. I'm not certain how it works with the pegulated version. If we're able to manipulate them like that, I don't know if it changes their stability or structure. I have no idea. So it's unless somebody knows.
So you would use that in a chronic inflammatory disease or what is its role in cancer?
Yeah, I mean, it's okay. Just quickly reviewing, not to take up Stefan's lecture here, but Clotho, I mean, that's a true sort of step towards age reversal versus just being super healthy. Now, we have to be super healthy and we have to detox and get the pathogens out of our body. We got to do all the things like Stefan is doing. But in general, if we want to go beyond that, it's my opinion, based on everything I've learned about Clotho, is that gives us an advantage to start to turn to really increase the human lifetime potential, because the desert mole rat produces Clotho their whole life, and they live like 700 human years, the equivalent to what, I mean, for a rodent, I mean, they live like 40, 50 years. I mean, how many mice do you know that are living 40, 50 years? They're like, I think they live like a year or two or something like that, not very long. And this one, its risk of death doesn't go down as it gets older. Its ability to reproduce is the same. I mean, it's incredible. So it's seen as a step towards immortality, which really means we're looking to extend life or buy ourselves healthy time, 20, 30 more additional years than normal. That's the thinking behind Clotho. Yes, to help manage chronic disease or regenerative. And I agree, we have to do all the other things. Clotho is the icing on the cake. That one can reverse fibrosis. It's a big deal. It is anti-cancer. It does flip on AMPK. It does all of the mechanisms that we're looking for, but it's also the master regulator of mineral homeostasis. When we're chronically inflamed and we're aging, our calcium balance is changing. You can say we're becoming calcified. We're losing the calcium from our bones, and it's depositing in our tissues. We're becoming stiffened. Our arteries are becoming stiffened, atherosclerotic. Our brains are becoming more fibrotic, the whole thing. And the way I see it, that has a lot also to do with the change in mineral homeostasis. As Clotho levels goes down, it is unable to regulate it the way that it has. And it also is involved it's not just calcium homeostasis. It's phosphorus homeostasis. It's this fibroblastic growth factor 23, which is important for vitamin D regulation. I mean, it actually helps to keep vitamin D from being too high. Okay, so, and I'm still getting it all sorted out, you know, with the parathyroid hormone and how they're all connected. But it's become clear that clotho, again, I'm always looking for those master regulators, the executive, the top of the top that's controlling those, all of the things below. And that's the only one. Yes, we have amlexinox that is involved, that flips on AMPK. It's anti-inflammatory, it's anti-fibrotic. But clotho is super anti-fibrotic. I mean, it's because it blocks TGF beta. But at the same time, what else is a master regulator of mineral homeostasis?
Right. And fibrotic diseases is one of unmet medical needs that we need to solve. And we don't have much of antifibrotic that's effective out there. I mean, you can say losartan is one of them, but we need to work on those antifibrotic drugs that is safe and can regulate the fibrosis. Because yes, as we grow in age, the fibrosis is exceeding the process of fibrosis exceed the parenchyma. That's why when we go up at the age of 90s, our liver gets fibrosis, cirrhosis, and everything gets fibrotic tissue, replacing the parenchyma tissue. Even the cancer favors the fibrosis because it squeezes the blood vessels, preventing the lymphocytes infiltrating. So the idea of loading exosomes with clotho, it's a great idea, not just for anti-aging, but also for cancer. In case you want to use exosome for cancer, just load them with clotho so you can break the fibrosis and prevent those fibrotic insulation of the cancer and open them up for the lymphocytes to infiltrate. And plus, you know, the type, you know, the fibrotic cytokines, fibroblast cytokines, it favor the cancer and it favor the polarization of the immune system to Treg, and therefore, you know, clotho, it's an anti-cancer and anti-aging. But again, because of its
It is,
expensive,
there is a difference between anti-cancer and reversal of cancer. Anti-cancer means that you don't develop cancer. You remain in homeostasis, you remain normal. Your normal cell does not get converted into cancer cell. But when we talk about cancer, we want to find out whether it would work on a cancer cell and differentiate and become a normal cell, or control the progression of cancer, or work as a treatment for the cancer. So, I mean,
it works both.
we know it won't
It
be
has
a single
anti-cancer.
agent.
It has both prevention and treatment. The clotho.
Okay, and so far the fibrotic changes and fibrosis is concerned, the dipyridamole works against the TGF beta 1, lowers
Yes.
volume, and it helps to reduce the polarization to the Tregs,
T-Rex.
which
Yes.
are,
Clotho that does that too.
yeah.
What does that?
Clotho, it does help to
No,
prevent.
no, no. What was the one, Dr. Patel, you said is?
Yeah, dipyridamole, that was the drug that was used like for the antiplatelet, not
Oh,
antiplatelet, but to release the additions of the platelets. And it was used in 70, but now the new drugs have replaced that. But that old drug was very powerful, very
okay.
powerful.
Antifibrotic. Oh, good.
Well, yeah, and again, my thinking is just I'm looking for the next level, the next thing that's going to be way more powerful. I mean, it's nice that we have something, especially I'm a big fan of some of the older meds that sort of get forgotten about that we don't realize how good they can be. But you know what I mean? Like clotho is something that we produce. It's not a drug.
No,
And if
you're
it's
right, but how easily is it available? Whether
It's in your urine.
well, we're making it available. I mean, we just have to have enough people ordering from Neo Biosciences. That's the best way to go because it's augmented.
All right, when we will talk, and I think that whoever wants to join you, they can
Well,
connect with you.
I am working with the company. Hopefully they will come here and sponsor us, and we will team up and come up with something for them. Yes. Meanwhile, we have Dr. Hartfield.
Yeah,
Me and
sorry
him.
about that, Stefan.
Yeah, Stefan, are you there?
Yeah, I'm here.
Sorry for cutting you off. You know, we get excited sometimes. Are you concluding the lecture?
Yeah, that was basically it.
Okay. Do you have any
Can I
questions
ask
for
one more?
Stefan?
Yeah, one more question, Stefan. Right now, carnivore, keto, paleo, and vegan is huge. It's just off the charts. It's what everybody's talking about. And myself, since I'm partially Norwegian, Irish, Danish, and German, I'm thinking that carnivore might be the way to go. Do you find that culture plays a huge part in our style of food in relationship to your labs that you've noticed with your patients? Or have you ever thought about checking that out with our ethnicity and our culture?
Yeah, no, I've talked to them about that before. I mean, my mom's gone as far as doing genealogical testing. She traced her ancestry back to a part of Ireland that's kind of isolated, and they subsisted off of mackerel. So she did a basically kind of mackerel type diet, and yeah, she likes that a lot. She does that a lot. You know, I've experimented with these things, but I think you can look back at your ancestry, kind of figure out what they were eating back then. You will typically find it's aligns with uh, two basic principles: is an animal-based diet. They hunted and they ate fermented things. They fermented everything because they didn't have refrigerators. And that was pretty much it.
Amen. Agree.
Dr. Hartfield, are you there? Let's hear from you, because I think we are going to do something together, possibly putting a Thursday for his group, me and Ham. I don't know. Are you still on, Dr. Hartfield? I thought we're gonna do something on Thursday together, having a compounding pharmacy to sponsor the event there, who has license in your state, right, Arkansas?
Right. I guess Thursday's about the only day that's left open. By the way, what a great group of human beings. My brain is blowing up here. So I hope these are recorded, Dr. Halasa, because I got to go back and replay it. Stefan, thank you for the contribution.
Yeah, send me the recording when you upload it, Halasa. I'll upload it to my YouTube channel.
Shell is recording it. Shell is here, right?
Okay, good.
I think Shell is recording the whole event.
Likewise.
I'm recording it, yes.
Yes, he's helping us. By the way, Shell is just volunteering here. Hopefully,
if you guys want a guy who knows about urine drinking, I know a guy. He can tell you all about the wonders of it if you guys are really going down this path with Clotho.
Yes, definitely. Might as well throw it in there. And I know Dr. Group is huge into it too, and Dr. Early and a couple other doctors.
Yeah.
And we have Bob too, the military guy, ex-CIA cybersecurity guy. Dr. Bob, if you're here, I think you and David will be a good team, because you have something in Arkansas, that building.
Yes.
Something.
Yes.
You and him. Did you exchange phone number and everything? Between
not
you,
yet.
David?
If you could make if you could make the introduction, that would be great. And
you know him.
This call.
Right?
This is the best. Yeah, we on the phone call, the last conference call, but I don't think we should exchange information. If we did, if you could resend it, that'd be good. And then I love this call. It was so wonderful. And so the best one yet. I like it when things continue to get better and better. And Dr. Halasa, what a genius that you are. And thank you for sharing the wisdom and for adding such great value and leadership to this group.
Well, I've been surrounded by smart people like you, and I think that's the reason, like Stefan and Hartsfield and Platts and Goldman and all those people. I think that's the reason. I'm learning from them. And I may be a little bit having some chemistry edge, but the information from Stefan, like, introducing iodine, Dr. Joseph, Clotho, Dr. Patel, she's like a wizard, applying everything she learns and adding more and contributing and involving, engaging. I think everybody here is intelligent, smart, and that's the reason why we have this kind of meeting. And the meeting that we have, and hopefully we're going to have something Thursday with Dr. Harshfield with this group as well. That we're going to have it like a discussion, more than one way or the highway. Because if other meetings where it's one way or the highway, you may end up having misinformation that's not being verified and clarified. That's the reason I want you to, people, audience here, if you feel that this information is wrong or you have something to correct, please come up to the mic and involve and engage and rectify it, because we want to make sure that we are using all your brains to verify those information and making sure that we don't have any bias or blind spots where things we don't see it. But thank you, Bob, for coming and attending.
Can we have Dr. land the plane? That's usually what he does, and we've missed you over on Dr. Lewis and Carter's site for the past couple of weeks. I know you've been busy with this facility, especially for veterans and responders down in Richmond, Arkansas. So, and I know that Robert would really like to hear about it, and it's pretty amazing what you're doing. And I know that Dr. Halasa is doing the same thing in Florida.
Yeah, and thank you, Joe. The Super Bowl, we're medical directors for the NFL Alumni Association, so we have to go out and do that. But our group is the Vets Wellness Institute. We met a great group out there called Vets for Vets, the number 4. Jameson Lewis, young man's name, firefighter. We are all doing this, and we have to get in the silo together. We've got 20 silos out there, and a lot of us are doing similar things. And Robert, you and I need to talk. Absolutely. There's no telling what I'm doing. And if I just talk to you for 10 minutes, I'm out.
I love it.
So
you're awesome. Hey, just so you know, Jameson just appointed me as the chief technology officer for his organization. And so I'm now the CTO for Vets for Vets. So every day you and I, we keep getting closer and closer.
But we're probably going to get taken up by the same alien craft. And so we'll talk to each other during our probings, whatever.
Sounds great. I'm signed up. And also for all of these different things, like I'm in. So just tell me where to send my check, and I'll try to help make these Clotho and other kinds of investments with the rest of the group to reduce the cost and increase the efficacy of our samples and our testing together.
Well, and to your point, there are so many funds that are available, almost $1 trillion available. The Congress has targeted for the veterans, but they don't know what to do with it. And the Vets for Vets are really solid because Jameson's a veteran. Our
100%.
Vets Wellness Village is going to be powerful too, because we're partnering with first responders, veterans, and NFL folks. We're trying, at the base of our pyramid, we want to take care of as many people as we can. The base of the pyramid is going to be what St. Jude's does for kids. Take care of all of this population, regardless of who we to pay. And that being veterans, the NFL alumni, the older folks with TBI and all that, and first responders. And there are people wanting to throw money at us. We don't, I mean, it's amazing. We just have to get organized, not fall into the issues. Some of the veterans group kind of got a little crooked in some ways. We don't want that to happen to us. And the thing that I think is important is having a home, a bricks and mortar home. I know it's an old school. We can do a lot online. It's amazing how much we can do with telemed and these folks. Then they come to Arkansas and see us, and we treat them. It's like we know them. Their wives are there and their kids, and we help. I mean, but you got to have a place. And a lot of the things that we're trying to treat are not an afternoon knee pain issue. It's a week-long, maybe several months for some of the veterans. And the Butkus Lodge, Dick Butkus died suddenly about 6 months ago. He was taking one of the anticoagulants they put him on, and he died that night. So who knows? But his foundation wants to build a lodge, 24 or 30 lodges, so these folks have a place to stay and have them housed in a way that maybe one veteran, one FL person, and one policeman or fireman. And
Yes.
having them together, that's been the most successful. I think we found this out accidentally, but that's kind of what we're experimenting.
Yes.
So anyway, there's that village in Redfield, Arkansas, just south of Little Rock. You're in Hot Springs with the Army Navy facility, and I need to get with you and help you get, put there into that little project too.
Yes, you got it. And so where we're at right now is Vet Tech offers $45 million a year, 25% cash up front. We're in the process of acquiring, now I'm a university as well, but we're in the process of acquiring 2 more universities, one in Pittsburgh, the other one in Nevada. And so that'll allow for us to take in Title IV funding, it'll take in GI Bill funding, and it'll go through and provide, the appropriate accreditation so that folks can earn all the way up to a PhD. And so with that, I like Vet Tech because it's $45 million a year, it's 25% cash up front. And so we're in our 4th round of approvals right now. And my plan was to accept the $8.3 million cash up front, and then to go through and to work with the Department of Interior and also the governor's office and the rest of them to accept the facility. Because right now, it's a $10 million liability that I don't want to have until after we get the proper funding. And if you come up with the right funding or investors or NFL people or whatever, they want to go through and rent that out to us, lease, be a 99-cent lease for 99 years. And so I'll work through that with you. And we've got fantastic protocols for central nervous system disruption and for CTE and TBI. Myself, I've been working with UC Berkeley and UCLA. My brain shifted on the Laplacian scale, 6 order of magnitude in less than 6 months. And so with that, I was using that super nutrient, which was the bee cappy, and then also the mimosa bark tea. And that was really wonderful because two doses of that tea cured my little sister of 18 months of stage 3 ovarian cancer. And then one of my CIA buddies, he found the weapons of mass destruction, and he was in a coma for 3 years. So CIA pulled him into MK Ultra. And when they did that, then what happened for him is that it rebuilt, they mega dosed him with some mycelium substrates. And with those adaptogens, it regrew his central nervous system and allowed his spirit to come back in his body. And then for SEAL Team 6,
how do we also link this up with people like Dr. Clearfield or Dr. Halasa or Dr. Lewis or Dr. Farshi? And what's the percentage with the government or Congress where there has to be like 20% veterans or 30% veterans? So if Dr. Halasa brings in 20 or 30% veterans, he brings in some of this money because he's trying to help the veterans. Do you know what I mean?
Yes. And so with that, there is a veteran-owned small business and a service-disabled veteran-owned small business. Right. And there are Native American Indian corporations and then Alaska Native corporations. And all of these things allow for us to do big contracts with the federal government. And so I'm happy to walk everyone through that. What I'd like to share with the group is that with Jameson, we've got $1 billion line of funding that's out there where the money people have already said they're willing to go through and give every single doctor $200,000, about meeting certain criteria for cash flow, equipment, longevity extension, A4M style stuff, functional medicine, chronic disease prevention and management, et cetera. So we've been working on how to make sure there's a win-win for everybody and that it advances our group's goals. So I like it when there's $1 billion and where there's money that can go towards building these centers of excellence that we've all been talking about. So I wanted to share that. And also, you're right, when there's $1 trillion for veterans, there's a lot more that we should be doing to collect it. And now that the federal law says veterans get to choose their own primary care providers, well, that's going to be a pretty big deal. And so now is an easier way to be able to reimburse. I had 2 other quick stories. The Master Chief Petty Officer, they made the TV show out of called SEAL Team. So that fellow went through and he had to assassinate a young boy, and he didn't like that, so it gave him PTSD. He went down to Mexico with the CIA and an organization, nonprofit called Third Option. They did 5 MEO DMT plus ibogaine, and that immediately in one session cured is reset his dopamine receptors and cured him of PTSD in one session. And so this next week on the 7th, if y'all keep me in your prayers, I'm going to go down and repeat that same protocol that the Master Chief Petty Officer did. I don't like recommending nothing I didn't try myself. So I'll share more about that stuff with you and about my clinical findings, when I come back on the 20th or
Bob,
so.
what do you have on Thursday?
And then also
what you have
Thursday,
on
I'm flying
Thursday?
out. Yeah,
Because
yeah,
I will
I'm
invite
flying
you to the because I will invite
I'm
you to the conference we have on Thursday with
Oh, no.
Hartsfield.
Oh,
But
well, thank you. So,
can
no,
you
I'm
come
gonna be
up with the building that has water spring, the one you show me?
Yes, of course. Yeah,
I want that.
And so
I want you to discuss it with Hartfield and how you can, because you may have things and he has things will make that building, because the building with water spring, hot spring, that's a big thing for me, because that is part of the treatment, especially when you do enhancement and they do anti-gravity in that hot spring. That's a win-win.
Bingo. Yep. Huge. And so I've got a whole protocol for all these things: hydrotherapy, equine therapy, forest bathing. We can do that because I got the 5 hot springs on Hot Springs Road in Hot Springs, Virginia. And then the facility we're talking about in Hot Springs, Arkansas, is 147 hot springs on Hot Springs City, Hot Springs National Forest, and then also more hot springs that are there, right? So it's really cool.
What is missing? Why you're not getting the deal? What maybe Dr. Hartfield can fill the gap.
No, it's $10 million in rehab that I didn't want to take until they funded us for the vet tech education. But if we find a different way to fund it, we put a group of investors, we put 1,000 people in there at a time. Now there's a limited use application for healing, and we meet all those 3 criteria. And we've got all of the cool people that know how to make this deal happen. The mayor's there, the mega church is there, the folks from Curtis Stout are there with us. We got a lot of different folks that are in tight, and even the Walden family and the rest of it. So Dillard's family, Dillard's heiress, there's a whole bunch of folks that's already there and signed off on this. We was just trying not to burden the state anymore until we could bring in federal funding. But we come up with other federal funding, we'll be winning a lot faster. And then also, just so that you know, Tony Robbins has been working with North Bethesda. He's been using lidocaine injections at the base of the brain. That shows a 100% PTSD recovery solution. And then SEAL team, not SEAL team, but Delta Force, they're using 18 hours a day, 7 days straight of an IV ketamine. And your spirit pops out of your body so long that you realize that you're spirit. So when you come back into your body, then there's no reason to kill yourself. And so with that, we're seeing 100% success rate with that protocol as well. So a whole bunch of different solutions. And there's a new electromagnetic MEG halo that you put on your head, a little headband. And that one's being able to specifically target areas of the brain to wake them back up. And then out in Oklahoma, I got another buddy of mine. He's got like a laser beam and then also an accurate ultrasound wand that'll go in and predabate like a square millimeter of your brain housing group or more if you like. So we've got all kinds of cool things, and then other ways of being able to methylate, chelate, remove any form of blockages that are in the brain, and there's a lot of different words for all that stuff, but I'm happy to go through and to share those things with you and remove the amyloid plaques, remove the aluminums, remove the heavy metals, remove the things that typically don't bind. And so happy to share that stuff with you soon as well. And anyway, I'm thrilled to be here with you guys. I love you, and I'm happy for us to share and bring in bigger pots of money. I like it when we start talking about trillions of dollars. It makes me happy. So, let's dial that in, right? And let's make that happen better. We've also got a whole hospital system up in Lynchburg, Virginia, and something to share with you. Got a young man that just made a deal about this thing called an Abunda box. So it's a Medicare thing. So you can get passive revenue by being able to pass care packages over to Medicaid patients. So it might be a nice, stream of passive revenue for everybody on the call. And do good, do well at the same time for everybody. Anyway, I'll share more with you again soon, but prayerfully this is a good start. Happy for those introductions. And yeah, by Thursday night, I'm going to be 3 sheets to the wind with this ibogaine protocol. And some Jewish rabbi Kabbalist that's been running these protocols, he's getting people off $1,000 a day, heroin addictions, cocaine addictions, whatever, alcoholism. they've actually cured 270 diseases with this ibogaine protocol that they're doing. So I'll share more about that with you again soon. Again, ibogaine being one of the strongest plant medicines, if you will, out of Africa. And so I'll share more with you about it soon, but I'm excited to go down and to have this visceral experience, and also continue to upregulate my own BDNF and develop greater neurological density so that I can remember half the stuff y'all is talking about on these phone calls.
Well, wait a minute, Robert. If you're going to be out in the eons and the source and the universal life, I need you to ask my dad something. He was at a putt, and I got to ask him something. So if you want to FaceTime,
send me a message. So turns out that there's more of a ketamine-like effect. So this is not like a bunch of multicolored stuff. It's a grayscale on the back of your eyelids. You open your eyelids up and you're completely sober, if you will. And then once you're at that level of source, then after 4 hours, you get 36 hours following approximately where you're just hooked up, tapped in, tuned in, turned on. You can ask any questions you want. So if you got questions for me, just let me know. And, I got a chance to participate in 3 resurrections already and all kinds of other, siddhis from the Yoga Sutras of Patanjali's. All these things are trainable. And so I'm happy to share with you the pathway that we can all become, better, and I'll just leave it at that. So I'm happy for us to share these solutions and bring our world to a happier, healthier, and stronger place.
Okay. One of the things about the ketamine that's interesting, we're starting to learn now that our brain, the neurons are sort of like the contractile elements in the heart. They create a pulsation and they move fluid at about 40 hertz. And if patients are a little sluggish, you can optogenetically or through sound bombard them with 40 hertz, and it creates this interstitial fluid pulsation to wash out the brain. It's very simple. And ketamine is that. And at some point, when I can get get in the room with an ultrasound machine, because it's very simple to do with non-ionizing radiation, I can watch the jugular vein flow. We've noticed the arterial inflow diminishes, which is surprising. I wouldn't have thought that, but we're going to learn a lot about how all the fluid moves back and forth. And this is cyclical. So it happens at night. It's hard to catch a person in their circadian rhythm. We're thinking in terms of using people that have sleep apnea or are unable to sleep. If we can just help them clean their brain out, then they can be awake 22 hours a day. You know? So
look, I've got a topical trans GSH glutathione put on the back of your occipital region, clean you out in a heartbeat. You take that, and then I've got another, what they call detoxinol out of Saber Sciences in San Diego. You mix both of those, you'll pull off almost anything out of your brain housing group, wake up being much, much clearer. And there's a place called BioCybernaut, another one called 40 Years of Zen. And they have these gamma protocols that are in there, 32 to 40 hertz, that'll go through and do the same thing. Donnie Epstein's Epi-Energetics will do a lot of the same stuff with basically a DO-led version of cranial sacral therapy. And so there's some really cool stuff that I'm excited to be able to share with you. And I didn't mean to talk over you, but did want to make sure that I shared that with you before those thoughts went fleeting from me.
No.
Let me add something here very important. Before you go to ketamine, I would like everybody to try to do intranasal progesterone with oxytocin, because progesterone works the same like ketamine. It has GABA effect, and also it inhibits the NMDA, same like ketamine. If we start trying it before we go to ketamine, and possibly if it's not that effect, in other words, potent, then it will help to decrease the dose of ketamine if you're using it after making sure the progesterone is being given. So something you want to add it to the equation.
No,
but
100%. Plus, I got a really good heart opening stack that goes with 900 milligrams of synthetic GABA. And then after an hour, then you do one dose, 2 pills of sassafras MDA. 10 minutes later, it's MDMA. 10 minutes later, it's psilocybin. And then 1 hour, but 10 minutes after that, then you go into this next place with an intramuscular ketamine. And then you do a booster 2 hours later. I lost 7.5 pounds of liquid memories with that protocol. And run it out of Tennessee, it costs about 13 grand. And so there's a way to do it for less expensive, but I just wanted to share that heart opening protocol. But the idea, look, if you're meditating, right, you can achieve this. If you're doing holotropic breath work, you can achieve this. The only goal for people that are in, a sympathetic dominant state is to go through and to say, hey, let's go through and shut everything down to parasympathetic, and then let's trance out. I mean, that's the goal. Whenever our spirit leaves our body, then our body's able to basically heal itself to its own divine blueprint. And so then you can bring more of your spirit back in there. And to be honest with you, I believe that that's what Jesus the Christ, who was also a yogi, went through and studied, and that was part of that being born again. And then I'll tell you another story. We've got the Air Force PJs are much more badasses than SEAL Team 6. And they're full doctors, by the way. So they're commercial doctors, they're DOD doctors. And SEAL Team 6 says that an Air Force PJ, pararescueman, is too dumb to quit. And I'll tell you why. It's because they kill them on purpose. And so they force their spirit out of their body and they resuscitate them multiple times during training. So with that, I got a whole new belief about this guy, radical dude that was around before Jesus called John the Baptist, in as much as that I believe that he was going through and asphyxiating people under the water and then bringing them back to life. So you could actually go through and force somebody's spirit out of their body, without having to go through and give them any of this stuff. And there's another box called the Life Force Light Portal, where you look at 8 different mirrors, a cat's eye light bulb, and then a marble, and you trance out. You're gone. Now, if you measure HRV before and then 45 minutes later, you measure HRV again because you tranced out, right? Like a mudra or a mantra or what have you, the ancient kind of Iranian practices, the Sufism, Zoroastrianism, etc. Anything before 6,000 years ago, 4,000 years ago, what have you, that you can measure HRV before and after, and you're 4 years younger for every session that you trance out with. So we just get people to a place that their monkey mind shuts off and the body will heal itself. If we remove the blockages, we can allow for more life force to flow in a better balanced way. So I'm happy to share more. And I didn't mean to talk over everybody, but I pray that some of these things that, also here's another cool one from SEAL Team 6, right? So when these guys, actually regular SEALs, when they do a night jump in a denied area, then, sometimes they land in the mud, they get multiple compound fractures, they got bones sticking out of their legs. Now, for over 20 years now, and they don't tell a lot of people this, but everybody on the call should need to know. So they use a non-steroidal anti-inflammatory like naproxen, but when you utilize that to reduce the inflammation so that healing can occur, then you also slow down the molecular bonding speed. So then what they do is they take a vitamin C and they megadose with it so that you can increase molecular bonding. So that 1-2 combo for them, again, megadoses of this, what you wind up with is that the bone is then able to come back in their body, their legs completely healed, and each one of the SEALs is now able to jump out of an airplane again within 5 weeks of the initial major injury. So just sharing a few functional solutions that may, add value to your practice and some of the logic that may support you and, bringing your solutions to that next level.
Just as an endpoint here, Robert, if you're done.
Yep.
Okay. Thursday evenings, let's start off with, like Dr. Halasa said, let's make it a kind of colloquial. I'd like to start with a difficult case or case that I've been having trouble with or thinking about to present. And let's consider, okay, have you thought about this, that, and the other? And that'll start things off. And then it'll be 3 hours gone with this crew before you know what happened. We'll be able to present our difficult cases kind of like back in med school when we had M&M conference, morbidity and mortality conferences. And that was the moment in time when it was on Thursdays, and the residents used to get up there and the staff skewered them, because it wasn't their fault, but they got to learn to take the heat. Here we go. And you learned from your mistakes and you presented, this person didn't do well. Now, those days it was serious. We killed people. We didn't mean to, but it happened. In this case, Mama's knee didn't get better, so we got to rethink that. It's not nothing, but worst thing happens mostly with our regenerative therapies is they don't work. They don't make people worse. But on the other hand, we learned so much from each other about looking at mammoth thyroid level and sort of things that we just forget sometimes. So I'll start and I'll present a case that just blew me away. And I'm old and I never heard of this. So if it's something I've never heard of, it's pretty rare. But I think we can learn from that. And then also we'll kind of go off from that case and then talk about other things.
Cool. That's awesome. Hey, so also, so you know that the Monroe Institute, they specifically have a class on soul retrieval and talking to your transition relatives. So that's a CIA school called the Monroe Institute. If you ain't been there yet, it's a pretty special place. They teach astral projection, psychic spying, remote viewing, a bunch of other things. But part of talking to your transition relatives is one of their mainstays. So just so that you're aware of that.
Okay. Well, with that, any other comment or commercials or anything, Dr. Halasa? I'm done.
Okay, well, good. So everybody's happy, making sure. We'll see you this Thursday, with the group of Dr. Hartsfield. I'm joining with them and see how we can resurrect another day, so we can have Monday, Tuesday, Thursday, and Friday. I think I'm gonna put Dr. Klatt so we can cover the 5 days. Okay, so it's just more or less, it's entertaining. It's a social gathering. We're having fun. Everybody has the mic. Anytime you can raise and talk. Okay, it's different from other places, so don't be shy.
This is not just a social gathering. I'm sorry. This is intense. This was absolutely intense. Okay, let's just be real. Just saying. Thank you, everybody.
Okay, good night, everybody. See you Thursday.
See you, John.
Yeah, lots of love.
Take care. Bye.